Welcome to the conference session titled Managing High-Risk MDS and AML. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. During this session, there are a few polling questions for the audience to participate in if you choose. Please click on the icon in the panel to navigate between the questions if you choose to answer. Today's specialist is Dr. Eunice Wang, who is the Chief of the Leukemia Service at Roswell Park Comprehensive Cancer Center. Dr. Wang joined Roswell Park faculty in 2003 and was appointed to the Leukemia Service of the Department of Medicine. She earned her medical degree from Keck School of Medicine, University of Southern California, completed residence training in internal medicine at Yale New Haven Hospital in 1999. Dr. Wang's clinical research focuses on the development of early-stage clinical trials for acute leukemias and myeloproliferative disorders. Her translational research interests involve the development of novel biological therapies targeting the bone marrow microenvironment for myeloid malignancies. With that said, it is my pleasure to welcome Dr. Wang.
Thank you very much for the wonderful introduction, and most of all for the opportunity to speak to all of you today on this very important topic. Many of you have family members or yourselves being affected by one of these diseases. And so today I will be spending some time reviewing the current and future treatment options for high-risk myelodysplastic syndrome, as well as acute myeloid leukemia. Shown here are some of my conflicts of interest and disclosures. So what is myelodysplastic syndrome, or MDS? Well, many of you know this is a disease that primarily affects older individuals. The median or average age of presentation of the disease is actually in the late 70s. And you can see here that the incidence or the number of patients who are diagnosed with MDS really increases rapidly with advancing age. The most often presentation that we see in older individuals coming to attention and being diagnosed with high-risk MDS is really presentations of low blood counts, whether it be a low platelet count, a low white blood cell count, anemia, or a low red blood cell count, or often 2 or 3 low counts, which may not have been noticed earlier in a patient's medical course, but come to attention when these numbers start to dip into critically significant areas. The most common reason for patients to come to medical attention is to develop a complication potentially related to low blood counts, and that includes increased risk of infections, bleeding, or fatigue, shortness of breath, or maybe exacerbation or compromise of their heart and lung function because of the low red blood cell count. Patients are referred to hematologists who are specialists who treat blood disorders, and this diagnosis of myelodysplastic syndrome is really made based on a biopsy of the bone marrow. As we know, the bone marrow is the source of all of the red blood cells and is the factory for stem cells within the bone marrow to produce white cells, red cells, and platelets. Looking here on the left-hand side of the screen, you can see a representative picture of cells from the bone marrow. And if this looks ugly to you, that is definitely true. Most patients have dysfunctional cells in the bone marrow, and they have increased numbers of what we call immature precursor cells, which really should number under 5% in a normal bone marrow and number between 5 and 19% with the patient with myelodysplastic syndrome. This is primarily, as we said, a disease of older individuals. So how do we decide how to manage this disease? This is actually a very complicated diagnosis. There is a gradation of severity of the disease. Patients with low-grade MDS can live for months, if not even several years, just having their blood counts followed expectantly, and may never need treatment at all, not even a single transfusion. Other individuals will present with more advanced stage disease and are going to require more aggressive supportive care, such as red blood cell and platelet transfusions much more frequently, as well as potential management to avoid infectious complications. So how do our treatment vary among these individuals is really based on the severity and the suspicion of disease progression. One of the most common ways that we classify or risk prognosticate in myelodysplastic syndrome is to use one of these classification systems. This one is called the International Prognostic Scoring System, revised in 2012, and really places patients' disease on a continuum based on the abnormal DNA markers or chromosomal abnormalities, the percentage of bone marrow blasts that are found, as well as the number and degree of the low blood counts found at presentation at the time of the bone marrow biopsy. Based on these criteria, we can rank individuals as having very low to low risk disease, intermediate risk, or high to very high disease. In general, the majority of patients are going to be in the low to intermediate category, and only a smaller percentage, anywhere from 10 to 20% of patients, may present initially with high or very high grade disease. Now, we know this is a continuum. As patients' disease progresses, they can move from a low to an intermediate grade or an intermediate to a high grade. And patients who have high grade disease or anywhere on the continuum may also have their disease transition into a more aggressive malignancy called acute myeloid leukemia. And now we know why this happens, because in detailed genomic analyses have demonstrated that as one ages, the stem cells in one's bone marrow acquire mutations. Now, these mutations can be acquired even a decade or 2 or 3 decades before the patient develops any clinical manifestation of myelodysplastic syndrome. But over time, on this continuum, some people progress sooner rather than later. These mutations initially are benign. They aren't associated with any change in the function of the bone marrow cells or the blood counts. As these mutations accumulate and the abnormalities grow and build up, patients may start to lose their ability to make normal counts and have a presentation of myelodysplastic syndrome. And again, as the disease progresses unchecked, a certain percentage, about 25% of patients that have MDS, are going to have their disease progress into an acute myeloid leukemia. An acute myeloid leukemia is a transformation of the underlying MDS in many patients. And this disease is characterized by rapid growth. Unlike MDS, which can be most often characterized as a bone marrow failure of the bone marrow to make normal cells, acute myeloid leukemia is characterized by the acquisition of certain growth characteristics that allows the disease to progress much, much more rapidly. These leukemia cells grow in the bone marrow, starting out from 20% marrowblasts and going all the way up to 80 to 90%. Again, the underlying disease can be highly biologically diverse, which has led to development of novel therapies for treatment of both of these disorders. And it happens in these patients tend to be a little bit younger than those that we see with the general MDS. How do we make that diagnosis? How do we characterize the disease? Well, as they say, the better you know your enemy, the better you're able to defend yourself. So what we do at the diagnosis nowadays in the current era is we not only confirm the diagnosis with the bone marrow, but we also do a number of diagnostic testings on that bone marrow biopsy, which allow us to better tailor and design individualized therapy for each patient. So, for example, as a specialist at an academic center, one of the most common things I do is when I have patients referred for either acute myeloid leukemia or for high risk or intermediate or any risk myelodysplastic syndrome, is I often will repeat the bone marrow biopsy, and patients will say, well, why do you need to do that? Because my doctor in the community already did that. And I said, I need to repeat it because the doctor in the community may not have done, for example, an extensive mutational profile and all of the markers and biomarkers that I need to better design a treatment plan for your MDS. In the community, many individuals will perform the bone marrow and perform basic testing, but more detailed analysis needs to occur for the specialist to better craft a plan for each patient moving forward. It's very important in talking about therapy for both high-risk MDS and acute myeloid leukemia to keep certain questions in mind. These are questions that patients have all the time, and these are questions that every clinician treating patients with MDS and AML really must actively engage the patient on in order to appropriately design and personalize therapy. So in addition to confirming that diagnosis with the testing as I just discussed, it's important to identify if there are mutations in that patient's disease that might make them amenable to what we call targeted therapy, usually with oral agents or pills, which can work as well or potentially even better than what we call traditional chemotherapy. However, chemotherapy is not for everyone. Most of the patients, as I know, have lived several decades, lived longer than I have, and certainly know what they would like from their life and what they want moving forward. So the question remains, is this therapy something that the patient will be able to tolerate? Is this something that the patient even wants? How does this fit into their lifestyle? How does this fit into their family dynamics? If patients are caring for example, an elderly spouse, or if they have mobility issues, or if they don't drive, or they're frail, or they have other medical issues. These are issues that really impact on what selection of a therapy needs to be. We also ask for certain individuals and those of younger age whether they might be eligible or interested in a bone marrow transplant. As we know, for many patients with high-risk MDS, as well as those with AML, the only what we call quote-unquote curative therapy is to replace the bone marrow with healthy, robust, new bone marrow stem cells. So this becomes an important question. And in those patients who are not particularly eligible or interested in clinical in that type of transplantation, oftentimes the best ways to prolong survival and quality of life is to participate in clinical trials. So I'd like to divide my talk into a couple sections. One, I'm going to talk about treatment of high-risk MDS because there are certain modalities and agents being developed specifically for that disease type. And then I'm going to end with a discussion of some of the targeted therapies and approaches that are being designed for acute myeloid leukemia. And then the third part of my talk will be for me to stop talking and for me to take questions from the audience as to what questions you have and what you would like addressed. So I'm going to start with the discussion of treatment of high-risk MDS. Now, high-risk MDS is MDS, which is typically found, again, in older individuals and is really characterized by either poor prognosis cytogenetics, in some cases by mutations that may predict for more aggressive disease or more rapidly growing disease, as well as the presence of multiple low blood counts, often not just a low white blood cell count, but a low red cell count, as well as low platelets. So these are patients that may already be requiring transfusions even every couple of weeks, or who are feeling chronically fatigued because of their abnormalities in their blood counts. So for these individuals who have intermediate to high or very high risk disease, the first question remains, these bone marrow stem cells are highly damaged. So is there any chance that this patient might be interested in a bone marrow transplantation, which would replace those very damaged stem cells in the bone marrow with healthy stem cells and would represent a path to cure? Now, as we know, very few percentage of patients, particularly in this older age category, are even interested in or eligible or able to undergo transplantation. So for those individuals, we would move towards treatment with chemotherapy if it's appropriate. Many times because of the planning involved, we can't obviously do an organ transplant at the drop of a hat. Many patients, even those going for transplantation, will require some sort of chemotherapy prior to moving to that procedure. So why are we transplanting patients with MDS? It's a bone marrow failure syndrome. It's not an aggressive malignancy. Why would we do that? And we don't do it in many patients. This is data showing that if you have a low or intermediate risk MDS, actually you'll do better with chemotherapy or with supportive care measures and not with the bone marrow transplant, as you can see here on this blue curve, because the transplant is associated with certain morbidity and risks that may actually not be beneficial for you in the short term. However, patients who have higher intermediate risk or high risk IPSS or risk classification MDS, you can see here that the non-transplant therapies in red as well as the transplant therapies tend to overlap. So it's in this category of patients that we're going to try to tease out where we're going with that transplant option, because in certain individuals, the therapy could be equivalent or better for certain individuals. The standard therapy for MDS for many years was just supportive care, transfusions, growth factors, antibiotics, antifungals, and management of the cytopenias as best we could. However, several years ago, there was development of this new class of drugs called hypomethylating agents, or HMA. These encompass two drugs, azacitidine and decitabine. And they work differently from what we think about in traditional chemotherapy. In traditional chemotherapy, we are administering poisons that are designed to kill off rapidly growing cells. And those poisons are associated, as one would imagine, with side effects against the normal healthy cells and in toxicities experienced by the individuals receiving those poisonous therapies. Azacitidine and decitabine are what we call epigenetic agents. They're not designed to kill off or poison all of the cells in the bone marrow. That seems to be counterintuitive. In a patient that has dysfunctional bone marrow that's not making that many cells, you really don't necessarily want to kill off those cells, because then you're not going to have any cells, unless you have a bone marrow transplant, to make more cells. What you want to do is you want to administer low-dose chemotherapy, which has the ability to go into the bone marrow, and as you can see here, in leukemic cells or in MDS cells, to turn on and turn off different genes. So you can see in a normal cell, this is your DNA. This is what we call these methyl groups here on the patient's DNA. And you can see here that these methyl groups are normally green, and these methyl groups turn on the genes, and those genes go on to make normal blood cells. In a patient that has MDS or has leukemia, those normal genes are turned off. And you can see all of these dots are now red. So these genes are not able to be turned on. These genes are needed for the bone marrow stem cells to make normal blood cells. And so these methyl groups, by turning off these genes, allow these cells to be dysfunctional and immature and not make normal blood counts. What decitabine and azacitidine does is they reverse this abnormal methylation. They turn these red dots to green dots. And by doing that, they turn on what we call the normal gene transcription. So they turn the genes back on. And so the bone marrow now has the ability to go back to its normal function, which is to make normal numbers of white cells, red cells, and platelets. And however, this process, because we're not killing the cells, but we're actually trying to turn on and turn off genes, this doesn't happen overnight. We're not killing the cells, we're trying to alter the biology of the disease. And so this type of therapy has to be given continuously, because you want to have this pressure on the bone marrow continuously. It needs to be given for 1 out of every 4 weeks. It needs to be continuously given, and it may require 4 to 6 months of therapy before we start to see an effect. It does cause prolonged low blood counts. It does cause some nausea, vomiting, constipation, and may increase the risk of infections while we're waiting for this to kick in. But in general, this does require a commitment of several months and a long-term commitment, because if it works, we generally need to continue this therapy indefinitely. Wow. What are the advantages of azacitidine? The advantage of azacitidine is that it can prolong overall survival. It can cause 2/3 of patients who have myelodysplastic syndrome who are transfusion dependent to become transfusion independent in terms of their red cell needs. By reversing these low blood counts and reversing red blood cell and platelet transfusion needs, we are seeing not only prolonged overall survival, but more importantly, improved quality of life for patients. If they don't have to come in every 2 weeks and feel awful when needing a blood transfusion, that's going to markedly improve their symptoms and their overall sense of well-being. Now, what can we do to enhance the effects of azacitidine or decitabine? Although these therapies are effective and they're very well tolerated, and importantly, they can be given continuously in the outpatient setting, my patients will often say to me, Dr. Wang, I don't know that I want to take this, first of all, indefinitely. Second of all, I'm not sure that I want to be able to wait 4 to 6 months from now to see an improvement in my counts. And then they'll say, do I have to come in every day for 5 days in a row or 7 days in a row every 4 weeks? Or is there an option for me to get my therapy at home, potentially, ideally in pill format? So looking forward, there are a number of therapies that are on the horizon for treatment of MDS. And I see that in the next few years, perhaps sooner rather than later, we're going to see these agents moving into standard of care therapy. However, right now, these agents remain experimental. So I just want to provide that slight disclaimer before I describe them. In general, here is a list of what I would consider the more promising drugs being developed for high-risk MDS. One are targeted therapies against specific mutations, IDH1 and IDH2 mutations, which were identified or can be identified on that initial workup of MDS that we talked about. In addition, there are some novel biological agents which are being developed, one of which is this pevinostat, which is an enzyme that deals with proliferation or degradation of cells. There is now an oral version of one of the hypomethylating agents that we talked about, and that is oral decitabine. And that oral decitabine is actually FDA approved last year. So we do have an oral HMA therapy that we can give instead of those continuous 5 to 7 day regimens. And lastly, we have some therapies which are designed to improve or enhance your body's own immune response to take care of the disease. And therefore, by stimulating or activating your immune system may be associated with less side effects than when we would see with sort of poisonous chemotherapy. So let's review some of the data on each of these agents. As I mentioned, IDH mutations are found in a very small percentage of patients. One would say probably 5 or 10% of patients that have myelodysplastic syndrome will be identified to have either a mutation in the IDH1 or the IDH2 gene. These two mutations, as you can see here, IDH2 can be found in the nucleus of the cell. IDH1 is found outside the nucleus or in the cytoplasm of the MDS cell. Both of these mutations affect this compound 2-HG and lead to the cell being stuck or arrested in an immature state. So these cells do not differentiate, and they're subsequently unable to make normal red cells, white cells, and platelets. Enasidenib is an oral pill, which has been designed specifically to inhibit mutant IDH2 right here. And so for patients who have MDS with mutant IDH2, it's possible to treat them either with enasidenib alone, which is a daily pill, or with enasidenib in combination with the azacitidine. And you can see here in very small numbers of patients, and these are 21 and 25 patients each, that you can see that about a quarter of patients treated with enasidenib, either alone or given in combination with azacitidine, will have what we call complete remission, meaning they will have improvement and normalization of their blood counts. A smaller percentage of patients are going to have what we call a partial remission, meaning they'll have some improvement but not complete count recovery. And you can see here that about 43% of patients treated with an IDH2 inhibitor alone will have some response. And when you add the azacitidine, about 84% of patients can have a response. So this is an agent which appears to be very effective, potentially as effective as decitabine or azacitidine alone, and in combination with azacitidine can really double the responses in patients. In addition, you can see here, as I mentioned, azacitidine typically takes about 4 to 6 months to go into effect. You can see here that the time to first response in these patients that had IDH2 mutant MDS was as little as 1 month. So not only can these agents work, and they can work in different ways and they can be additive, but they can actually work faster for patients, okay? Hemiminostat is a different small molecule inhibitor. It's a small molecule inhibitor of this particular enzyme called NED8. What does NED8? It's involved in degradation or the breakdown of DNA and DNA replication. So it is an important enzyme in the whole DNA processes, and of course could have effects in patients that have dysfunctional genes due to those same sorts of DNA alterations occurring in MDS. In preclinical or in laboratory models, the combination of azacitidine working to restore normal gene transcription does synergize or work together very well with the application of this particular NED inhibitor, which also can affect that DNA processing. In this particular study, patients who had higher risk MDS, 59 of them, were enrolled on a clinical trial where half of them received, again, the standard azacitidine that we've talked about, and the other half received that NED enzyme plus azacitidine. Again, you can see here that the complete remission rate in patients with azacitidine alone or restoration of normal counts has happened in about 24-27%. And this was doubled when we administered the NED inhibitor with the azacitidine alone. And you can see here that patients who responded to this combination, they responded for almost 3 times longer. And the median time to have a response was a little bit faster. Instead of over 4 months, it was actually 3 months. Oral decitabine is an exact, we think, translatable product. So when we're moving from, say, an IV medication to an oral medication, it's important for us to recognize that because you're taking it in a totally different route, is it as effective as the IV formulation? And do you get the same potency? You certainly don't want to take a pill for convenience sake that is less effective. And these studies, which led to the approval of oral decitabine, very convincingly showed that the oral formulation of the decitabine was about 98.9% equivalent to the IV version. And in this particular clinical trial, patients who had higher risk MDS were randomized in cycle 1 to get the pill, and in cycle 2 to get the IV. And each of these, and the other half of the patients were randomized to get the IV, and then were randomized to get the pill. And when we measured the levels of the decitabine in both of these groups, we can see that the equivalency was approximately 98.9%. So this should give you confidence that the oral decitabine is about 99% equivalent to the IV decitabine. Lastly, I mentioned that we want to talk about immune therapies and ways to activate the patient's own immune system to treat patients with MDS. And so there's a couple of approaches that are currently in development. One is this drug, MPG456, which is like very difficult to say, but this is actually an antibody, and this antibody blocks this particular process. It's called TIM3. TIM3 is involved in activation of your immune system to recognize and destroy malignant cells or MDS cells. And so administration of this antibody here, which is blocking TIM3 on the patient's immune cells, could lead to those immune cells being much more active in responding. And again, in laboratory testing, the combination of azacitidine and this TIM inhibitor seem to work better together than independently. So again, here are the results of some early trials looking in high-risk MDS as well as newly diagnosed AML. And you can see that the combination of this anti-TIM antibody plus either decitabine or azacitidine really enhances. Again, we go from a sort of a response rate about 20 to 30% to about 60%. And it didn't seem to matter whether you got the decitabine or the azacitidine. When you combined it with this anti-TIM antibody, you did about 2/3 of patients had demonstrated benefit. We also saw benefit in patients with newly diagnosed, as well as in patients with acute myeloid leukemia who had a little bit lower responses in these disease categories than in high-risk MDS, but certainly sort of intriguing data showing that an immune activating antibody can work very well with either decitabine or azacitidine to enhance responses without adding any significant toxicity that we would see with a high-dose chemotherapy regimen. This is another agent which has really gained a lot of traction for the treatment of both chronic and acute leukemias, and now pre-leukemia states such as high-risk MDS. This drug, venetoclax, is a drug which blocks a protein called BCL2. This BCL2 is upregulated by MDS as well as AML cells, as well as a wider range of cancer cells, to allow these cells to not undergo programmed cell death. Normally what happens is your cells live their normal lifespan, and they die. When you administer cytotoxic chemotherapy, those cells can die sooner rather than later because of the effects of all of those traditional chemotherapy drugs. This BCL2 protein, however, when overexpressed in those cancer cells, allows them to survive, not only to survive beyond their normal lifespan, but also to become resistant to chemotherapy or even epigenetic therapy. And in this particular study, again, patients were treated with the azacitidine backbone, in addition to administration of this oral BCL2 inhibitor, venetoclax. This combination has been established as a standard of care for treatment of AML patients, which we'll talk about in a minute. And you can see again, when you combined this BCL2 inhibitor with azacitidine, again, you're seeing very, very high overall response rates, over 70% with the combination of a pill added to that azacitidine. Again, for patients achieving a response, it was much faster, only 2.6 months for patients to achieve a complete remission on therapy, instead, again, of the 4 to 6 months that you would need to wait with azacitidine alone. And for many of these patients, you can see 50 to 60%, 70% of them also became red blood cell and or platelet transfusion independent, meaning they didn't need to have those transfusions anymore because they were responding to the patients. Lastly, interestingly enough, we talked about how we use azacitidine or hypomethylating agents sometimes as what we call a bridge to that allogeneic stem cell transplantation. And although very few patients do go on to that stem cell transplantation, in this particular study, they went on to receive about 21% of patients that were treated with this combination study were still able to achieve a response and go on safely to that subsequent bone marrow transplantation, which is an important endpoint. This drug, magrolimab, is another immune antibody. This immune antibody doesn't work on T cells or B cells or those portions of the immune system, but really actually works on this other cell that's very important for anti-tumor immunity, and that's called the macrophage. What the macrophage does and what its job is to be the Pac-Man or the eat me cell. What happens is when your body identifies a foreign substance, a bacteria, an invader, a virus, an infected cell, even a tumor cell that's gone, it's a normal cell gone bad. The job of the macrophage is, once that aberrant cell has been identified, its job is to remove that cell from the normal microenvironment and the normal bone marrow. So those macrophages, once they become activated, recognize that the cell is going rogue, will then actually go and engulf that tumor cell and get rid of it, physically remove it from the body, sort of like when some kid is misbehaving in school and the teacher takes the monitor or the principal comes and actually removes that cell from the classroom, that's what the macrophages do. But they get rid of those cells that are tumorous. Now, many tumor cells have figured out a way to evade that process, and so they express a protein called CD47. Cells that express CD47, for whatever reason, cannot be seen by the macrophages, so they don't recognize that that cell is aberrant and needs to be removed. So if we could block that CD47, all of a sudden, we could recognize that that cell is bad or that student is bad and still remove that cell from the environment. And so that's what this antibody does. The CD47 antibody, again, in combination with azacitidine, seems to work better in achieving the immune responses. This particular drug, however, has some limitations. Red blood cells actually also express CD47. So when you block CD47 on the cancer cells, you also block it, you also activate it or block it on the red blood cells. And so there is a process where maybe some patients experiencing this drug can actually have severe anemia when the treatment starts because of this cross reaction. But regardless, the addition of this anti-47 or this macrophage initiating antibody in combination with azacitidine, again, very effective. We were seeing, you can see here in first line, newly diagnosed higher risk MDS patients. Again, about 50% of these patients had a complete remission with this combination therapy, and another 30 to 40% had evidence of improvement. Again, median time to response was less than 2 months, and these results were very durable. Patients had responses that lasted very, very long periods of time. As you can see here, the blast percentage or the number of abnormal cells in patients who had MDS and AML was really markedly decreased by this combination therapy. So all of these agents are currently moving forward in development, and hopefully we will see them moving into further confirmatory studies as well as approval in the next few years. Currently, many of the drugs that I just mentioned right now are only available in the context of a clinical trial. So again, if you or your loved one has high-risk MDS and is interested in learning more about any of these therapies, I would encourage you to speak to your treating physician and or to seek out whether a local academic or larger medical center might have some of these options available for you. Now I'd like to move on to treating patients who have acute myeloid leukemia, which, as we discussed, is a much more aggressive disease and slightly different beast than high-risk MDS. So unlike MDS therapy, which is really right now, I think, a little bit limited by, again, the lack of FDA or commercially available drugs, there's been a bonanza of drugs approved for the treatment of acute myeloid leukemia over the last 3 years. You can see here on this timeline that initially we had just high-dose chemotherapy, which was developed at Roswell Park, I have to mention, my institute, in the 1970s. And then between 1973 and 2017, there really was very, very few progress. I mean, this timeline spans 40 years, and there really was one drug that was approved and then withdrawn from the market, and essentially 7+3. However, starting in 2017 all the way to 2020, you can see now that there have been 9 different drugs approved for the treatment of acute myeloid leukemia in that time frame, which is huge. However, it's important to recognize that each of these drugs only treats a subset of patients that have this disease. So again, the number of these agents does not mean that we have 9 agents available for every patient. It means that if we're lucky, we are able to select a more targeted and effective therapy for certain subsets of patients, as opposed to just standard 7+3 intensive chemotherapy, which we had in the past. We also know that a lot of this progress and the reason that these drugs have been approved for the treatment of acute myeloid leukemia is really based on our advances in research and in science and technology. Our ability to rapidly sequence hundreds of mutations in that leukemia or MDS cell has really been a game changer and has really been the incentive to spur on all of the clinical things that we see now that we can give patients. For example, our ability to sequence hundreds of genes simultaneously at the time of diagnosis in a cancer cell has allowed us to better understand the complexity of the disease that we face in both MDS and AML therapy. This is a list of many of the genes that we see at the time of initial diagnosis in a patient with newly diagnosed acute myeloid leukemia. So I'd like to highlight a couple things. One, there are a couple genes here, FLT3, NPM1, DMNT3A. All of these are found in 20 to 30% of patients newly diagnosed with AML, but you can see there's no drug that is found in more than 20 to 30%. So there's no dominant mutation that's found in even 50% of patients with AML. What about all these other mutations we've identified? You can see all these other mutations are found in less than 1 to 10 patients diagnosed with AML, and sometimes only found in 1% of patients. So again, this is an incredibly complicated disease that is difficult to treat. Lastly, I'd like to point out that not only is there many genes, and many of them are only found in very low concentrations, but these genes sometimes can occur together. So this is what we call a ribbon graph. And on a ribbon graph, if there is a gene over here and it is linked to a gene over here, then those are found together in the same patient sample. So you can see here the FLT2 gene is often found in conjunction with the NPM1 gene mutation. The NPM1 gene mutation, again, is also commonly found in combination with the IDH1 or 2 mutation. So again, adding to the extreme complexity and challenges that we face in dealing with this disease. Not only do we have challenges in the underlying biology of the disease, but we also have challenges in the number of patients and the type of patients that we're seeing. So as I mentioned previously, acute myeloid leukemia is an aggressive malignancy, and the average age of presentation of acute myeloid leukemia is a little bit lower than we find in MDS, with an average age of presentation in the late 60s. So in addition to having patients who are in their 60s and 70s and sometimes 80s, about a third of patients are going to be diagnosed under the age of 50 or 60 years of age. So the fact that there is a wide range of younger individuals who also can get treated with this cancer makes treatment needing to be much more individualized than if it was only found in older individuals. Looking at this treatment algorithm, you can see the first thing that one needs to do is to assess the patient, again, to ask them many of the same questions as we discussed previously regarding patient decision, lifestyle, eligibility for transplant, eligibility for clinical trial. Then we do what we call that comprehensive diagnostic workup of the leukemia cell. And with those two pieces of information, or with that information at hand, we then would determine, is the patient eligible for that same intensive chemotherapy approach that we use so successfully since 1973, or is the patient ineligible for intensive chemotherapy and needs to be treated with a lower dose regimen, similar to what we discussed would be standard of care for patients with MDS. The disease biology can also dictate whether patients are able to receive targeted therapy. If you look at certain DNA or chromosome abnormalities, we can use chromosome abnormalities to divide patients into, again, different risk classifications: favorable, intermediate, and poor risk. Patients with favorable risk are often offered more intensive approaches if they're able to tolerate it. Patients who are not going to respond to intensive chemotherapy regimens are because they have poor prognosis disease may be treated with totally different agents. And again, the presence or absence of specific mutations, those IDH1, IDH2 mutations, those FLT3 mutations, or other mutations such as P53 can render those patients eligible for targeted inhibitor therapy that does not necessarily require intensive chemotherapy. Now, until 1973, the gold standard therapy for acute myeloid leukemia was this regimen, 7+3, 7 days of this drug cytarabine, 3 days of another drug, either daunorubicin or idarubicin. And as you can see here, this is the gold standard and has been the gold standard since the 1970s. I just want to highlight here one of the initial papers describing the successful use of this regimen primarily in older patients. And again, just wanted to throw in there, these patients again were treated here at my institute. So if you are young, you are fit, and you have acute myeloid leukemia, again, we are going to offer you a therapy which uses as its backbone this standard 7+3 that we just discussed, with some variations. If you have what we call favorable risk genetics, we may add an antibody drug conjugate to the 7+3. If you have an FLT3 mutation, we may offer you a FLT3 inhibitor plus the 7+3 backbone. If you have acute myeloid leukemia coming out of a prior MDS, which is what happens increasingly in many older patients, we may offer you, if you're able to receive it, a different formulation of 7+3 that works better in patients that have what we call a secondary AML arising from a prior MDS. And then if you don't have good risk features of your leukemia, you may get a regimen that includes that BCL2 inhibitor that we discussed earlier, because we just think that you're not going to do well with that intensive therapy. So let's walk through again some of the therapies for acute myeloid leukemia that are currently commercially available. This FLT3 gene is one of the most amazing discoveries in acute myeloid leukemia. It is found in about 25 to 37% of patients that are newly diagnosed with acute myeloid leukemia, more frequently in patients that are younger. We know from many studies that patients in the past who got treated just with chemotherapy alone had a much shorter overall survival when they were treated with chemotherapy, because the presence of this FLT3 gene did seem to confer resistance to standard chemotherapy, and many of these patients will relapse within a few months. There are two FLT3 inhibitors. Both of these are pills, which are designed to specifically target this mutant FLT3 gene in patients with this disease. The presence of this FLT3 gene leads to activation of signaling pathways. It makes the cancer cells grow faster and be resistant to chemo. So if there's any way we can block the mutation and turn off these signaling pathways, we may be able to improve responses to standard chemotherapy. And that's what happened. The use of this drug, midostaurin, which is a drug that inhibits many different gene mutations, but does inhibit FLT3. The addition of this pill to standard 7+3 did lead to improved overall survival in these patients that had newly diagnosed FLT3 mutant disease. The majority of these mostly younger patients also went on to allogeneic stem cell transplantation. So they also had a benefit from being able to get the drug up front, not relapse, and allow them to go on to a potentially curative transplant. This compound, gemtuzumab ozogamicin, has a checkered past in AML therapy. This drug was initially approved in 2000 for treatment of patients with relapse and refractory acute myeloid leukemia. However, over a 10-year period, it was noted that this gemtuzumab ozogamicin antibody, which is attached to a DNA damaging chemotherapy drug, had some significant side effects, particularly in patients who are going on to that stem cell or bone marrow transplantation. So for concern about some of the toxicities, specifically liver damage with the use of this antibody drug, this drug was removed from the commercial market in 2010. However, it was reapproved in 2017 because when they took this antibody drug chemotherapy conjugate and added it to that 7+3, they found, particularly in patients who had favorable genetic markers, that it improved event-free survival. Okay. And although there still was this liver damage and abnormalities, when we administered the gemtuzumab, not just as a bolus medication, but in 3 smaller doses, the liver toxicity really fell to under 5%. And this was felt to be a reasonable toxicity in this setting. As I mentioned previously, there is a new, what we call liposomal formulation. What does that mean? That means that we take the 7+3 drug, and the 7+3 drug, unfortunately, in the body only lasts a very short amount of time. So when you administer the cytarabine chemotherapy to patients within their bloodstream, it only lasts for about 15 minutes. So many patients getting the 7+3 regimen needed to get this cytarabine drug 7 days in a row, continuously infused into their body. Otherwise, that the drug will be gone within 15 to 30 minutes. And therefore, you need to have this continuous 7-day infusion to kill off all of the leukemia cells in patients. Well, what you can do instead of doing the continuous infusion is you can make the drug last longer in the body by and wrapping it into fat molecules. So essentially taking your water soluble drug, putting it inside a fat droplet, allows that drug to penetrate into the bone marrow and to stay in the bone marrow for longer, and therefore allows it to kill off more leukemia cells in patients who have difficult to treat leukemias. Now, the administration of the specific liposomal or lipid or fat-based 7+3 regimen was found to be particularly helpful for patients that had AML arising from prior MDS. Patients needed to be younger than needed to have achieved a CR to go to a transplant. Not only did these patients respond better with administration of the fat-based 7+3 than normal 7+3, but more of them were able to go on to a transplant, and potentially because those lipid-based chemo was better at killing off cancer cells in the bone marrow, more of them were able to be cured with allogeneic stem cell transplantation after a fat-based 7+3 than the standard 7+3. Now, not everybody can go on to an allogeneic stem cell transplantation. Many patients, for various reasons, donor issues, personal issues, family issues, even financial, social reasons, can't all go on to get a bone marrow biopsy. And for those individuals, when they finish chemotherapy with high intensive therapy, they may need what we call maintenance therapy or administrator of lower dose chemotherapy to contain their disease. And so for these patients that are getting intensive chemotherapy but may not need or may not go to transplant, we have now developed an oral azacitidine formulation. Now, this oral azacitidine is not the same as IV or subcutaneous azacitidine. This is a much lower concentration of drug. It is given for 14 days, and it's only given for patients that have acute myeloid leukemia. We are hoping that we can discover a way to use the oral azacitidine for the treatment of MDS, but at the current stage, this oral azacitidine is only used as low-dose, long-term therapy in patients with acute myeloid leukemia. Now, what about the older patients with acute myeloid leukemia who have what we would say not as fit for chemotherapy? We have many of the same therapies that we would offer these patients as we offer patients with high-risk MDS, and that includes this venetoclax BCL2 drug that we discussed in patients with newly diagnosed acute myeloid leukemia above the age of 75 years or who have significant medical problems. The use of azacitidine plus the venetoclax leads to overall responses in 67% of patients and prolongs overall survival. Now you can see here that the overall survival, as we note, with patients with acute leukemia is shorter than those with MDS because of the aggressive nature of this disease. But the combination of this low-dose chemotherapy and this pill has opened up avenues for treatment for patients in older age groups. We also know that patients that have IDH1 and IDH2 mutant disease can also benefit from these IDH1 and IDH2. So we have used these drugs both in the upfront and the relapse refractory setting for treatment of patients who have these mutations, similarly to what we're developing for the treatment of MDS. For patients who have disease that is recurring after chemotherapy, there are many options still. We see again, the mutation data can be important if patients have evidence of that FLT3 mutation, we have another inhibitor, gilteritinib, a much more potent and effective newer generation FLT3 inhibitor for treatment of patients with FLT3 mutant AML. And lastly, we are developing again immunotherapy for treatment of both MDS and AML. We have antibodies which are able to bind both the AML cell and the patient's immune system cells to directly and potently activate the patient's immune system to kill off the leukemia. We also have developed what we call chimeric antigen receptor, or CAR T cells, where we can harvest T cells from patients, genetically modify them, and put them back in to target their own leukemia cells. In fact, we are also now collecting T cells from healthy individuals, modifying them and giving them to patients that have MDS and AML. And these, what we call off-the-shelf CAR T cells, may have some advantages over the patient's own cells in that these are healthier cells. They don't have to be transfected or transduced. They can be given right away. However, there are some limitations with that. So we are looking at whether these CAR T cells can represent a way forward for treatment of this disease. So I've taken up a lot of your time today, and I just want to conclude by saying there's a lot of hope and enthusiasm for treatment of both of these diseases in the academic world right now. As I gave you a laundry list, there are multiple new therapies that exist and are on the horizon. For patients who have MDS, azacitidine remains the backbone, but I'm looking forward to the use of additional agents in addition to azacitidine to improve responses in high-risk MDS patients. I'm also looking at additional targeted and combinatorial approaches for treatment of patients with acute myeloid leukemia. And for both diseases, I think immunotherapy represents a high point, and maybe we're going to start to see some of those immunotherapy agents that are so effective in other cancers starting to make an impact in these diseases as well. In conclusion, I'd like to remind you that any clinical decision-making that occurs must be a shared decision-making process between the patient and their family with the treating physician. Clinical trials offer many new options for patients, but the decision to undergo therapy and the selection of therapy should be made based both on the patient, their personal desires, as well as the biology of the disease. And just because we have novel therapies in clinical trials doesn't necessarily mean that they're the right option for everybody. So in conclusion, I'd like to thank you very much for your attention today, and I'm happy to address any questions. Thank you very much for the opportunity to speak, and I hope you found this talk useful to you as you go forward on your journey in MDS and AML therapy.
Thank you so much, Dr. Wang, for the wonderful presentation. We have just a few minutes to take some questions, and then any questions that we don't get to, we will make sure that we get people the answers to. So our first question is, how does a doctor choose between using Dacogen or Vidaza in high-risk MDS?
I think that choice is really based, I think, sometimes on what the patient would like. So I personally, for medical reasons, like to give the azacitidine or Vidaza because I feel that it is well tolerated. It doesn't cause a lot of low blood counts, and it is a shot under the skin for my patients. So it's an easy thing for them to come into the clinic, get a shot, not have to have an IV placed, and go home. So it's well tolerated, doesn't drop the counts, ease of administration, short visit in my clinic. Other patients who may be already transfusion dependent and already have an IV in place or potentially a PICC line may prefer the IV decitabine because they already have an intravenous access, and the fact that it is 5 days of administration as opposed to 7 days. Other people feel that they don't tolerate the shots, or there are certain patients that develop allergic reactions or skin reactions, hives, or just don't tolerate having injections in multiple sites. And for those patients, an IV administration with decitabine may be preferred. The last thing is that decitabine is more what we call myelosuppressive. So it does drop people's blood counts a little bit more significantly than Vidasa. But in that sense, it tends to be a little bit more potent. So for patients that have higher white blood cell counts or patients who have acute myeloid leukemia, we sometimes will use decitabine in place of azacitidine because we feel that it more quickly brings down the white blood cell count than the Vidasa. Many times, though, it's a decision-making, considering all of those factors with the physician to decide better into a patient's regimen. Many times, patients who start with a subcutaneous Vidasa can switch to an IV version of Vidasa if interested. And I do have patients that, for convenience, can switch between decitabine or Vidasa, but the two drugs are not 100% equivalent, so that needs to be discussed with your clinician.
Thank you so much. And we are coming to the end of our session here. So the questions that we didn't get to, we'll make sure that we get everybody their answers to. So thank you so much, Dr. Wang, for sharing your time and your expertise with everyone today. And if you'd like to watch this session again at a later time, it will be available on the conference platform within the next hour by accessing the session and clicking on replay. Or you can also navigate the on-demand tab in the platform hub. As I said, I know we were not able to get to some of the questions, but we will be able to get you your answers. And if you'd also like, you can send us your questions either to our help account, which is help@aamds.org, or you can submit your question on our Facebook page, or give us a call at 800-747-2820 extension 2. Please be sure to visit our exhibit hall. Our next session will start in 15 minutes. And on behalf of all of us at the foundation, I'd like to thank you for joining us, making us your resource of choice on information on bone marrow failure. Our medical advisory board and team are always here to help you and your family, as we've done for the past 37 years. This concludes our session.